right, good morning, everyone. Can you all hear me okay? Okay, great. My name is Trung. I'm a physical therapist here at John Knox Village, and thank you for attending. Thank you for those who are watching at home. And today, what I'm going to talk about is pain management. So, what I'm going to talk about is the prevalence and sources of pain, describe methods for pain management, and help you understand the role of therapy for managing pain. So about 50% of community-dwelling older adults suffer from chronic pain. And 75 to 85% of the elderly in nursing homes also suffer from chronic pain. This high prevalence of pain is due to chronic or acute conditions such as osteoarthritis, soft tissue injury from falls, or even medical treatments such as surgery. So what is the importance? So actually among the elderly, pain is often undertreated or untreated. Pain can affect and impact your quality of life and health. It could lead to depression, anxiety, social isolation, sleep disturbances, immobility, increased use of health care. But basically the self-report is the gold standard for pain assessment. There's just people who with dementia may have difficulty expressing their pain, and in response may show facial expressions, but people may misunderstand that and not understanding that may not understand that it's actual pain they're experiencing versus some emotional outbursts. So the gold standard to getting treatment for pain is to make sure you report it. So according to the International Association for Study of Pain, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. What I also want to bring to your attention is a new way of understanding pain. So pain is once thought as to be an indicator of injuries of the body tissue. It is also now known that pain can also be a warning signal for potential damage. So going to back to the definition, where it's that sensation with association with an actual or potential, we can actually use that feeling of pain to help protect us. So these are just examples. Not all types of sources of pain, but just some examples usually found in the elderly. You can see the list there from rheumatoid arthritis, osteoarthritis, bursitis, spinal stenosis, fractures, pressure ulcers. You can see even fibromyalgia or pain from cancer, even dealing with oral, dental, or chest pain, swallowing. All these are sources of pain where physical and occupational therapy will usually treat pain from a musculoskeletal origin. So pain can be characterized in two different ways, whether it's duration, how long you've had the pain, or what's causing the pain. So duration of pain, you have acute versus chronic pain, and then the cause of pain, whether it's nociceptive versus neuropathic. Acute pain, usually it's a shorter duration, usually within the first 72 hours or up to a week you'll experience acute pain. We define subacute pain as lasting 1 to 6 weeks. So typically it doesn't usually last more, actually doesn't last more than 3 to 6 months, but it's usually temporary and it resides with healing. Acute pain results from some sort of injury or surgery or disease-related tissue damage. It's usually caused by something specific. Chronic pain, that's where the pain is ongoing or persistent for more than 3 to 6 months and can even continue even after the injury or illness that caused it has gone away or been healed. Chronic pain may or may not be associated with a disease process. So chronic pain can even last years and years on end as well. Going on to describe causes of pain. So one category is nociceptive pain. So what happens is when a tissue is injured or potentially injured, spinal nerves called nociceptors send this information back to the brain to warn of damage. So the body responds in order to minimize that damage. So for example, if you walk and sprained your ankle on your left ankle, your immediate response is you're not going to try to put any more weight or pressure on that left foot to result in more further damage. So those signals are sent to the brain, and then signals from the brain go down to that sprained ankle, and the healing process starts. So you get some swelling, which brings in the healing cells at an area, and then usually that's so nociceptive pain is usually localized and is responsive to treatment. Another example here, so for an example, a person with osteoporosis, so have a low bone density, can easily fracture, whether from a fall or even turning and twisting to reach for something can cause a compression fracture in the spine. So that's a known source of pain, and this could respond to treatment. Neuropathic pain is caused by some sort of pathology in the peripheral or central nervous system. Some examples are diabetic neuropathy, postherpetic neuralgia, which is a complication from shingles that affects the nerve fibers and causing burning pain after the rashes appear. There's also phantom limb pain, so those who had their limb amputated will feel this ongoing pain even though after the limb has been amputated. Neuropathic pain is usually more diffused. It's not as localized, so it's more diffuse and less responsive to analgesic medications. So you can see here that on the left-hand side is a healthy nerve cell and healthy blood vessel. And here this represents somebody with diabetic peripheral neuropathy. So you can see here the blood vessels is nice and clean and healthy, able to provide nutrients such as oxygen to the nerve and keeping it healthy and working as how it's supposed to work, versus somebody with diabetes and uncontrolled high blood sugars can cause blockage in the artery. And so blockage in the artery weakens the wall cells of the blood vessel, and that means less nutrients, less oxygen goes into the nerve. And that damages the nerve, meaning the signals aren't firing as fast as they should be or picking up the signals as well as they should be. So normal aging may be associated with impairing the neural network for pain. So we can see that sensitivity for pain of low intensity may decrease as you age. That sensitivity to heat pain or pain applied to the head may be reduced as you age. There's a little evidence, though, to support that the elderly experience less pain. Aging has no strong effect on pain tolerance. So as I had mentioned earlier, older individuals with dementia, again, may be just more confused and not able to express the pain that they're having, but they can also experience pain too. Sometimes elderly are more reluctant also to report pain due to slower processing of those pain signals as well. That could potentially lead to delay in treatment. So as you age, wider recruitment of neurons are needed, and there's a possibility of that processing being slower. So what is pain management then? It's a multidisciplinary approach for improving your quality of life and easing the suffering for those living with chronic pain. And so this multidisciplinary team usually consists of your primary care provider, whether that's a physician or nurse practitioner, pharmacist, psychologist, psychiatrist, and also your physical occupational therapist. So next we're going to look at some pain management strategies. They can be broken down to non-invasive versus invasive. Non-invasive, you can see, can be broken down to pharmacologic or non-pharmacologic. And invasive may involve injections such as epidurals or cortisone injections, and also surgically implanted devices. So with non-invasive pharmacologic pain management, you may be prescribed analgesics, either narcotics or NSAIDs, also known as non-steroidal anti-inflammatory drugs. You may be prescribed muscle relaxants or adjuvant analgesics. Those are type of medications that are not primarily designed to control pain, but can be used for that purpose. So for example, antidepressants are thought to work by increasing the levels of certain neurochemicals at the nerve endings to help inhibit the pain signals. Anticonvulsants such as gabapentin can help with nerve pain. That medication can help by either blocking the excitability or increasing inhibitions to balance that hyperexcitability of the nerve pain. Non-invasive, non-pharmacologic pain management includes physical or occupational therapy. We're looking at use of exercise or manual therapy, education, or modalities. There's also cognitive behavioral therapy, or CBT, which focuses on the solutions, not necessarily the root cause for the pain or problem. Basically, CBT encourages to change or modify dysfunctional emotions, thoughts, or behaviors, so you're learning skills such as coping or stress management, or relaxation, assertiveness. Some invasive pain management strategies. So injections you may be familiar with, such as epidurals or cortisone. There's also prolotherapy, which is a non-surgical orthopedic procedure that works by an injection directly at the source of the injury to, quote unquote, trick the body to repair again. So it basically is recreating this mild inflammatory response, so it encourages new growth of tissue to repair that injured tendon or ligament. There's also surgically implanted electrical therapy devices, so a surgeon can insert like internal electrical stimulation unit to help control the pain, or surgically implant like an opioid infusion pump, so that you're using that to medicate yourself internally. So muscle relaxants, again, that could be prescribed to help with pain, which doesn't directly go to the source of your pain. It provides more an overall sedative effect on the body. So for example, if you're experiencing back spasms, if you're taking a muscle relaxant, that's just going to provide this sedative effect on the entire body, not specifically your low back. Some examples are Soma, Flexeril, Valium. Some risks, some habit forming can occur if with taking with alcohol or other drugs. Could impair mental or physical function. May see urinary retention in males or change in sleep cycle. Although I know usually with muscle relaxants, it's generally recommended to take it at night before you go to bed. So for mild pain, you have non-opioid analgesics such as acetaminophen or Tylenol, and then your NSAIDs such as ibuprofen, naproxen, or COX-2 inhibitors such as Celebrex. The benefits of acetaminophen helps reduce fever and mild to moderate pain, doesn't cause upset stomach or heart problems. Side effects are rare when taken correctly. The risks, it could cause liver damage if taken more than the recommended dosage. The benefits for NSAIDs, it blocks the chemical reaction that leads to inflammation, but as you see, some of the risks could cause kidney damage or stomach problems, and can also cause blood thinning. For mild to moderate pain, you may be prescribed opioids or narcotics, such as codeine, hydrocodone. As you can see, the trade name Vitican, Lorcet, Lortab, oxycodone, also known as Percocet or Oxycontin, or Ultram, also known as Tramadol. For severe pain, you may see morphine immediate release or morphine sustained release, transdermal fentanyl or hydromorphone, also known as Dilaudid. Opioids are most effective for pain management for no longer than a 2-week period, have a dissociative effect that help patients manage the pain. The risks, the biggest one, as you may all know, is the strong potential for addiction and tolerance with extended use. And there's also some side effects such as nausea, constipation, drowsiness, cognitive effects, confusion, and depression. So I want to take a moment here and talk about the opioid epidemic. So since the mid-1990s, the healthcare system has employed this approach to pain management with this focus on pharmacologically masking the pain instead of treating the actual cause of the pain when the source can be identified. So this strategy led to just this dramatic increase of prescribing opioids, which led to this widespread of opioid misuse and addiction. In 2012, healthcare providers wrote 259 million prescriptions for opioids. That's enough for every American to have their own bottle of pills. 1 in 3 long-term opioid users say they are addicted or physically dependent. And their household members were even more likely to believe the opioid user would struggle to discontinue use of it. 4 in 5 new heroin users start by misusing prescription painkillers. In 2015, heroin deaths surpassed gun homicides, where 8 years prior to that, gun homicides outnumbered heroin deaths more than 5 to 1. In 2016, you can see that more than 42,000 people in the United States died from opioid overdose, which also includes 17,000 whose deaths were attributed to prescription opioid overdoses. In the last 15 years, actually, deaths caused by overdose of prescription opioids have quadrupled. And in Florida alone, prescription drugs are responsible for more than 60% of all narcotics found in drug-related deaths. And this opioid use disorder has increased more than 750% over the last 26 years in Florida. So how did this all started? So back in the mid to late 80s, there was this big push to increase the use of prescription opioids in response to this unmet need that there's a large number of people experiencing pain, but unfortunately, they've been unmonitored, not attended, not satisfactorily managed or treated. So there's been a lot of people who have been undertreated, quote unquote, for pain. So by the early 90s, the American Pain Society began to argue that a new approach needed to be used to assess and treat pain. It was recommended that clinicians be held accountable for pain management and put in quality assurance standards that could be used to measure pain, which then suggested that pain should be the 5th vital sign. So the four main vital signs that we usually assess is body temperature, heart rate, respiratory rate, and blood pressure. And so now they wanted to add in this fifth vital sign, pain. So that's what happened in 2001 with the Joint Commission published these new standards that clinicians in hospitals and medical centers to assess pain in all patients. Make sure that patients have the right appropriate assessment and management of pain, and that pain is assessed in all patients. And so it even comes down to, even with my documentations, even an outpatient, where in order for me to complete my documentation, I have to write down a pain rating number. So yes, I do, of course I care about how you're feeling and how you're doing with your pain, but I'm also asking to know so that I can fill in the paper, but also knowing, okay, how to progress. Has your pain levels changed? Has it still 8 out of 10 when we first started? Has it gone down, or is it staying the same or gotten worse? But finally in 2017, the Joint Commission noted that after this release of these standards back in 2001, that there's some concerns now that these standards could lead to inappropriate use of opioids. So in 1991, prescriptions of opioids were 76 million, which increased to 97 million in 1997. So why this large increase of these prescriptions? So between 1997 and 2013, there's a company called Purdue Pharma had their drug Oxycontin approved by the FDA. And the labeling from the FDA approved for this drug claimed that addiction to this drug was rare and that abuse was unlikely. So these claims were used by Purdue Pharma by basically flying in all these physicians, providing this all-expensive paid room and board dining, telling all these physicians that you should prescribe our medication, Oxycontin, to help with pain. Essentially misleading the physicians that the abuse was unlikely and addiction was rare. So like, as I said, these claims were misleading or false, and Oxycontin is twice as potent as morphine. And in 2011, the CDC revealed that that prescription painkiller overdoses had hit epidemic levels, killing more Americans than heroin or cocaine combined. It's just some more statistics here. Sales of prescriptions of painkillers to pharmacies and providers was increased by 300% since 1999. In 2010, 12 million people ages 12 and up admitted that they were using these prescription painkillers non-medically. And then more than 40 people were dying each day from overdoses involving prescription opioids. Currently, Purdue Pharma has been sued for all this by the states, and the current agreement is the Sackler family, who owns Purdue Pharma, would pay as much as $6 billion to help communities address the damage from the opioid crisis. This lawsuit's still ongoing, so the final court ruling is to be determined. With that being said, I just wanted to be clear that opioids do have a role in addressing pain. Drugs, pain medications have a role in addressing pain. But modern society often puts a premium on quick fix solutions to complex problems. So according to the CDC, non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain. The contextual evidence reviewed found that many non-pharmacologic therapies, including physical therapy, weight loss for knee osteoarthritis, psychological therapies such as CBT, and certain interventional procedures can help with the chronic pain. So I'm going to go back to my earlier slide of the definition of pain. And again, I just want to highlight that pain is it's unpleasant. So physical therapists, we're movement experts, and we will help identify the source of pain. But also we want to also use methods that we have new evidence for, that managing pain doesn't solely just focus on that injured tissue. It also, we need to address other factors such as stress, the environment, social considerations that may influence the amount of pain that you're experiencing. So this brain and body approach to managing pain is also important in response to understanding the purpose and nature of pain. So before I continue, a show of hands from the audience. Who right now is experiencing acute or chronic pain? Okay, I would say maybe a third of you, the audience. As I had mentioned, for acute pain, physical and occupational patterns, whether your gait pattern is affecting how your pain is, or address muscle weakness or stiffness. Look into any previous injury or past events that could be contributing to that pain, or fear or negative emotions. As I have experienced with some of my patients, that some of the blockage of progression is actually mental. So looking at like why, mentally speaking, aren't able to progress. So we're going to look at either those negative emotions or fear that could be resulting in inhibiting your progress. This is just an example here of some treatment techniques you may see in PT and OT. So exercise, strengthening exercises, stretching to improve flexibility, cardiovascular fitness, so improve your muscular endurance to help you walk longer for prolonged periods of time. We'll use manual therapy, so joint mobilization, soft tissue mobilization to improve the mobility of your joints and soft tissues. Trigger point release, so there's some knots. Sometimes you have knots in your muscles that we'll look to reduce to help with your pain. Myofascial release helps with your connective tissues, your fascia, to help that be more mobile as well. We may use modalities to help treat pain, and I'll go into those in more detail later. We may involve motor control exercises, so that involves training and isolating your deep trunk muscles and making sure they're contracted properly, and further integrate these muscles into more complex tasks, so that helps coordinate and optimize your control of your trunk muscles for your spine. Also education on lifestyle changes. I'm big on hydration and nutrition, posture awareness, and proper body mechanics. So those are important to help maintain proper posture when you're walking, or proper posture when you're trying to lift or carry items. Work on adaptations to reduce pain-provoking activities. Talk about stress management, sleep hygiene, and even some pain neuroscience education. So a lot of people come to me and automatically think when you come to doing therapy, you have to work really, really, really hard. No pain, no gain when you come to therapy. That's the only way you're going to get better. Totally incorrect. Totally incorrect. When you come to therapy, we're not here to, again, put more additional stress on whatever injured tissue that you have, but to manage it better, reduce the stress on it, to educate you on load management. What I rather consider to you all is no pain, no gain. Know your pain, have a better understanding of your pain, and know how to make gains. So we're going to teach you exercises and other techniques to help get you stronger, walk better, but also techniques and strategies to prevent falls, prevent injuries to occur again. Again, we will start low and go slow, not going hard, high intensities if it's not for you. But again, it gets you to move. Another couple of phrases that I've learned from a patient actually was motion is lotion, rest is rust. So really, encourage you to get out of bed, get out of your chair, to stay active and move. So lastly, what I'll talk about is different modalities. I talked about briefly about exercises, but briefly talk about different modality techniques that we use to help with pain. We use ultrasound, which provides this deep healing effect. So sometimes we use a hot pack for pain. That's more like surface level, but with ultrasound, we'll apply heat deeper. 2 studies have shown the effectiveness of using ultrasound specifically for calcific tendinitis of the shoulder and carpal tunnel syndrome. But you can see the benefits of ultrasound helps increase blood circulation to help the healing process, increase in tissue temperature, which helps with decreasing the tightness of your muscles or tendons. Oops, wrong way. Also, there's non-thermal effects of ultrasound, so increasing blood flow, cell permeability to again help bring in nutrients and getting out of waste products, reduce edema or swelling. There's also electrostimulation. This works by stimulating the peripheral nerves. This produces action potential along those nerves, and these sensory the signals get sent towards the spinal cord in the brain, which produces this tingling sensation. The thought or theory of this is called the gate theory, where applying the electrostimulation, let's say, to the low back, because of back pain, by turning on the electrostimulation, it's producing the electro signals that's being sent to the brain, which then is blocking or gating the pain signals. So you're having this relief of pain. Unfortunately, it's more temporary relief, and there are times where it may last maybe an hour or 2, or it only lasts a couple of minutes after using it. But at least it helps reduce some pain and enables you to move more. Oops, going the wrong way again. A TENS unit, or transcutaneous electrical nerve stimulation, is basically a portable unit that you can purchase and have at home. And you can see the different areas you can use on your low back, your knee, your neck, shoulder, wherever you have pain. The only contraindication of using a TENS unit or electrostimulation is if you have a pacemaker. You can't use this if you have a pacemaker. Microcurrent point stimulation is a little different than electrical stimulation. This uses low frequency concentrated direct current. A TENS unit uses alternating current. And in the studies that they've done, they've actually, when development of the TENS unit, they try to use direct current on these test subjects, and it actually causes burning effects. So they nixed that and decided to use alternating current, and then is selling the product as that to help relieve pain. Versus use of direct current, the studies have shown is to help highly effective in treating, relaxing the muscles, calming the nervous system, and even treating scars and adhesions. It utilizes principles of electrostimulation and acupuncture. So there's different acupuncture points that I would go to help alleviate the pain. In terms of calming the nervous system, we have our autonomic nervous system. It's broken down to sympathetic, which is our fight or flight response, and our parasympathetic system, which controls the homeostasis of the body or balance. So things that we don't really control, like our heart rate per se, or activity in the intestines or glands. It basically puts a big reset button on that. It helps calm the nervous system down so it's not as hyper active. It also helps reduce endorphins, which are hormones, or basically the body's natural painkillers secreted from the brain to help give you a more relaxing effect. So you can see up here, this person is getting treated for their neck right at the cervical roots, cervical nerve roots going down to help with neck pain. This individual here is getting scar release therapy using MPS. What I find is people with history of abdominal surgery, whether that's taking their appendix taken out or gallbladder taken out, whatever abdominal surgery they have, leaves this scar, big scar. And over the years, what that does is it pulls on your fascia, which is this connective tissue that lays in between your skin and on top of your muscles. And over time, individuals with back pain, that complain of back pain, it could be from this scar right here. So that scar is tightening up the fascia, which pulls on your back and can cause back pain. And with individuals that come to me with back pain, but also have a history of abdominal surgery, I usually try to go here first to help reduce back pain. I've had good results. Basically, the idea is all that scar tissue here underneath has developed into positive cells. Healthy skin cells are negatively charged, and scar tissue cells are positively charged. So by using MPS, we can do is reverse the scar polarity. Reversing those polarity of the scar tissue cells from positive to negative, and reduce the tightness of your fascia, which help reduce pain in your back. Myofascial release is a hands-on technique. It's more gentle, so it applies this gentle sustained pressure on the fascia, which is a connective tissue, to help eliminate restrictions and pain. So here is your muscle, and your muscle is considered bundles of bundles. So your muscle is a bundles here of these fibers, and then the muscle fibers are bundles of muscle cells. And you can see the each bundle of fibers is surrounded by the fascia. And this is also an example of the fascia. And so using myofascial release is to help reduce the restriction of this area here to help restore motion and decrease pain. So in summary, I want to highlight that pain is an actual normal and natural part of life. It's a protective mechanism designed for us to help to survive. Without it, we would not be able to respond to a threat or injury. Pain cannot be prevented, nor should be. So that's why the title of my talk today is Pain Management, not Pain Prevention. The key to pain management, though, is to stop the progression of pain from that normal acute pain to becoming that chronic type of pain that prevents us from doing the things that we love. So again, the gold standard for pain management is self-report. Tell your doctor that you're experiencing some pain, and well, look into different options for you. And not only your physician, it requires a multidisciplinary approach. And of course, therapy is there to help restore your level of activity, get back to the things that you love, back to things that you want to do. Are there any questions? Okay, I have one question. You're gonna have a mic, so you can speak into the mic, so the viewers at home can hear you.
I was wondering if using a TENS unit would be helpful with plantar fasciitis.
So the TENS unit can help provide temporary relief, but I wouldn't say it's the main go-to for me to help plantar fasciitis. I find what works more is ultrasound, and I find what helps also is manual therapy and taping. I do taping to help adjust where the foot needs to be, so put less stress on the foot. So what I would evaluate is the foot flat? Is it overarched? And try to correct that with taping and help reduce the load and stress on that plantar fascia. Any other questions? One back there.
Do we need a doctor referral or Martha referral?
You can go get a referral, yes. And in the state of Florida, there is direct access as well, which you can be seen by therapy for up to 30 days before you need a physician referral or Martha's referral. But if you can get a referral, I think it would be best to also talk to your primary care provider first too. But we do have that option of direct access as well. Any other questions? One over here.
When you keep having, pain, electrical stimulation, pain pumps, and implanted such things, do you ever get to the point where it's just you keep doing it and it just tops out? I mean, you just can't keep using something like that to control the pain because you've hit the height of it, and I mean, you can't keep adding more. You've kind of used up the advantage of it, and it just kind of stops working.
Of those devices, you mean?
Yeah.
Again, it's so. I guess I'm trying to understand your question. Is can you top out or plateau with the use of implanted devices? I think you can top out. It will provide again some relief, whether that's temporary mainly, and we'll have to look at other sources of treatment that will be appropriate for you and your diagnosis. Again, coming to therapy, looking at whether manual therapy or taping or myofascial release or microcurrent point stimulation, other techniques to see besides using drugs or an implanted device to help. So basically we need to look at, from a physical therapy perspective, is what is your pain and what's that pain limiting you from doing? And I want to look at your goal for what you feel like you're being limited by, whether if it's your shoulder, if you're limited by reaching and putting on your clothes, we'll look at techniques to help and restore that motion while reducing the pain for you. So it really depends also on what your goal is too. Okay, any other questions? Okay, well thank you. Thank you for coming. Thank you for watching.